the eye and systemic disease. The problem we have with medicine is everybody works in their own particular silo. Cardiologist, the heart, the vessels. Optometrists, the eye, oftentimes focusing on refraction. Ophthalmology, the reason why Dr. Loudon says don't go to an ophthalmologist if you want to get tested is because they fall under the category in most hospitals as surgery. So that's what their expertise is. Lasers, surgery, things like that. That generally does not solve the eye problem, and definitely does not solve any systemic body-wide problem that could be causing the eye to have a problem. So we have a big problem here. So the only way you have of solving this is to recognize the interconnectivity of disease. Now, all glory and honor to what I'm telling you today from my mentor, Dr. Tremp, who was the top ophthalmologist in the world and potentially the top doctor in the world when he was practicing, because he had a unique advantage over every other doctor. He could see visually through magnification using ophthalmic instrumentation changes in vessels, changes in nerves. Imagine if a neurologist could open up your brain and see the nerves. Imagine if your cardiologist could open up some window in your chest and see the vessels in great detail inside your body. That's what Dr. Tremp could do. And the problem with the silo is that a lot of doctors are reticent to do this. I'll just mention his first name, but the clinical and medical director at the place where Dr. Tremp was the retinal specialist, said Dr. Tremp is doing things way beyond any other ophthalmologist in Massachusetts, at Harvard, at Mass Eye and Ear. But I cannot refer patients to him because he's not practicing standard of care, and therefore there's a liability issue in referring people to Dr. Tremp. Craziest thing I ever heard, but absolutely true. So, but Dr. Tremp had a very good, tight following of individuals that heard about him. None other than Edmund de Rothschild. These people owned governments, and his wife, both of whom had macular disease and would come to Boston every 6 months for treatment with Dr. Tremp. So he was quite a scientist, even though he was trained as an MD at Harvard and practiced there at 47 years. And I think, really what I'm referring to, and the reason why the eye is important, is there are really 3 pillars of health measurement. So risks and determinants of health. We do a survey for that. What risk factors, what historic issues have you had in your life? What's your timeline for health? Have you been bitten by a tick? Do you have bleeding gums? Is your gut a mess? Things like that. Those are very important. And those are very modifiable risk factors. The next thing is physiology or biomarkers in your blood. And if your risk factors are adverse, your blood will eventually tell that story. Maybe not immediately, but eventually will tell the story of adverse risk factors. Then closest to disease are not physiological markers. They'll be part of the story. But when we start seeing pathology changes or tissue changes is by definition disease, really. So when your risks go up, then your physiology changes adversely, then you can start seeing tissue deterioration. Your body's always in a repair and recovery process, so that tissue changes are only going to start erupting when you're losing the deterioration, repair, and recovery battle. Okay, and change in pathology is the best indicator of your future health. In some ways, in terms of predicting that it's near, risks are actually better because they're further away. The only problem with risks is the risk may never manifest in a pathology change. So pathology tells you for sure things are going wrong. Okay? And the best place to look for pathology changes is anywhere in the body. But the easiest place, and probably the most precise place, is to look at the eye. Neurological tissue, retinal ganglial cells, retinal nerve, thickness and volume, looking at amyloid formations, which are a sign of infectious disease or inflammation. We can see all that in the anterior and posterior cavity of the eye. So the front and back, all over the eye, we have indications of or ability to see pathology changes. So I just want to cover, anybody wants an eye test, this is the process. You order the eye evaluation. It's on our website, and there's the link for it. Find, and as Dr. Loudon pointed out, find an optometrist. We don't want a surgeon who's going to, over-treat you or treat you unnecessarily or not help us get the cause. You find an optometrist with an OCT, optical coherence tomography, and here's one group, Vision Source. Here's another group, All Docs OD, or you can find a local eye doctor that has an OCT. Take our form to the appointment. So on this website URL, there's an image of an eye. You click on it, and it opens up a PDF file that you can download and take with you. And we'd like your optometrists and their office staff to take the test listed on that sheet and fill out their opinion. Don't tell them you're going for an eye evaluation for systemic health or Alzheimer's or cardiovascular health, whatever. Just say you want an eye exam. Okay? But we would like to have their comments and opinions on what they're finding. I am not trained in eye. My son is an optometrist, so I often send stuff to him if I need a more detailed assessment of what's going on in your eye scans, and he does that for me because I pay his phone bill. Okay, so that's the father-son relationship, right? Here's something important. The images produced by these optometric instruments and ophthalmic instruments are extremely precise and accurate and give very detailed images. But very often those images, which are maintained on the computer systems of that optometric office, they're lost in the translation when they send them out to you, to me, whatever. So my recommendation is take your phone, which has a high-resolution camera, and ask to take pictures of the images. They're your eye, not the optometrist's eye. So take pictures of that, and then you can easily send them to me. Now, in theory, it's a HIPAA violation if you send them over unsecure means, but if you send them, you're basically authorizing that it's okay to send your eye images. And if you want, you can sanitize them, you can download them to PowerPoint and edit them and whatever, and then send them up. If they fax them, which is the normal way of communicating health information from office to office in healthcare to stay within secure privacy laws, HIPAA laws, it's almost useless for eye testing because the resolution of faxes are so poor, black and white, that when I see it, it looks like it's just a blob of black and white. It's very hard to interpret. So the resolution is lost by orders of magnitude when you fax it. Now, I do have a fax number on the sheet as an option, but I prefer the eye doctor send you the digital images via email or send them to me. My email is on the form, or you take the digital pictures yourself. Upload images to Get Healthy rather than email it to me, and that way they go in the documents. Healthy is a HIPAA secure private database, and so you can just put them up on documents. I'll get notified that they're there, and then we can talk about them, and I can see high resolution. You don't have to do this, but if you do load them up on the system, you can notify us via chat that your images are up. Not normally, every time someone loads something up into documents, I'm notified. Encourage your eye doctor to make notations on what they're seeing, and do not indicate that you are there to be evaluated for chronic diseases. They'll get paranoid. I had one eye doctor. I sent a patient to the eye doctor on Cape Cod, and the eye doctor told the lady she had no need to have an OCT, and turned the patient away. So OCT measures down to microns in terms of resolution, and your eye cannot see anywhere near microns. So I realize now that that eye doctor was Superman, because if he knew you didn't need an OCT, that must mean his eyes have super resolution. Of course, I'm being facetious, but it's like, you can't make it up. He turned the patient away. But anyway, craziest thing I ever heard. But, if they're not going to do an OCT for you, don't go. Because, yes,
Tom, I would just say that it just simply shows his level of expertise. That's all.
Yeah, well, it's just, or fear of liability. We don't know. So anyway, I love this image of the eye, but, the eye is a window to your soul, but it's a window to your health, My little puppy dog, which is under my feet right now, her eyes tell a lot more about her mood than anything else. There's no question about it. But why is the eye special in terms of measuring pathology compared to any other tissue in your body? Okay, and this Wayne Strahline was a professor at Harvard, full professor in ophthalmology, along with Dr. Tremp. And he talked about ocular immune privilege. Imagine if you bang your thumb and you have inflammation there and it swells, okay? Put ice on it, wait, the swelling will eventually go down. But see, the eye is arguably the most precise instrument in your entire body. The focal plane is critical in terms of the light coming in and focusing that light on the fovea in the back of the eye and the retina, creating that image, converting the light into an electron and sending the image back to your brain for you to see it. Anything that disrupts that focal plane will cause your vision to go askew. Okay? So the eye actually has a mechanism to sort of downregulate any inflammatory process in the eye so you won't have swelling or inflammation that could affect that focal plane and could distort your vision short term or longer term. So in that respect, according to Strahline, is that your eyes actually have a reduced inflammatory response capability compared to other tissue. Therefore, it's a canary for inflammatory diseases. So, you can use imaging, ultrasound, things like that to look at pathology, MRI of the brain. But the eye is going to be much more sensitive because of this so-called ocular immune privilege. Okay, and that's what makes it so profound. Now, let me tell you, we've talked a lot about infectious disease and Charles Mayo forwarding the concept of focal or localized infection. So in other words, and that ties back to local inflammation. So there are going to be instances where the eye is not a predictor of disease elsewhere in the body because of the focal or localized nature of inflammation. But so often as you have a focal or localized inflammation, it can migrate and become more whole body, and the eye will eventually pick that up. But when it comes to the brain, the eye very frequently, I won't say 100% for sure, but very frequently is a canary for what's going on in the brain, much more so than another tissue. But still, in terms of pathology, it is the best screening tool. Why? Low cost, non-invasive, extraordinarily precise and accurate instruments to measure it. And lastly, you get to spend time with guys like Dr. Loudon in the eye exam, or probably better yet, my son, the other Dr. Lewis in the family. So enough with that. And so I'm just here, I'm just sort of like re-emphasizing sort of the continuum, lifestyle and risks, physiology, pathology, then disease, And since our society is hardwired for instantaneous gratification, Madison Ave, we want, we don't do things until it's late in the game, and we want something that's highly titrated, not something that's 20 years off like risks. I'll worry about that when the risks are a problem. So the eye, in terms of instantaneous gratification and showing actual disease, is above, nothing else is above that in terms of its utility. And I just picked this image this morning because, we see the optic disc, but you see all the micro vessels. With OCTA, and that is the preferred device, but I don't specify you have to go to an eye doctor with OCTA. But OCTA stands for Optical Coherence Tomography with Angiography. So it's looking at angio, blood vessels. It's looking at the micro vessels. It's literally looking at the connection between the arterial and venous. And you can't really see them here, but there are all kinds of little spin-offs, micro vessels coming out of here. And in OCTA, you can see the integrity of these. You can amplify the signal, magnify that, and see, are the little teeny capillaries starting to deteriorate or atrophy? There's no such thing as big vessel disease. I'll show you these images later. Every vascular disease, and most chronic diseases stem from vascular diseases, are diseases of the smallest vessels in your body. I tell this little story with my, in population health, folks that aren't necessarily as inclined towards health as some of you folks are. Denise, don't take offense, because you're definitely on top of your game there up in Viking. But, I say if you have a sink and you have two different basins and one has a little teeny drain and one has a big drain, and you're filling them both with dirty water with particulate in it, which one's likely to clog first? And, everybody says, well, the small drain, okay, the small vessels, okay? And then I always respond to them. I say, you now know more than 99.9% of cardiologists, because they're all worried about the big vessels. But it's the little vessels that are telling the story of what might happen in the large vessels. Okay, it's a microvascular disease. And I can tell at the rate I'm going now, we're going to have part 2 of the eye and systemic disease next week. So prepare for that. And then the week after that, we're going to talk about body electric, just as a little heads up. 69,000 ICD-10 codes for diagnostics in the standard of care. And in my world, Dr. Carter's world, 4 mechanisms drive them all. 4 mechanisms. Guess what? That applies to eye diseases too. Holistic body. These same mechanisms affect eye. The other reason why the eye is so important, not only because of ocular immune privilege, but there's no tissue in your body that has higher blood flow. Not blood volume, because the eye is very small, but higher blood flow than your eye. Your brain has 10 times more blood flow than average tissue. Well published. That the brain consumes 25% of the oxygen in your body, but it's about 2.5% the mass of your body. So 10 times more. The eye is even more than that. Why? Very simple. Small, concentrated, extraordinarily active tissue. Your eye is like a hummingbird in the animal world. Okay? Fluttering around at 10,000 beats per second. So the choroidal vascular structure underneath the retina is the most dense of any vascular tissue anywhere else in your body. So things that are going on in your systemic vessels will affect the eye at a higher rate because there's so much blood flow. So much blood flow indeed. So, I've shown this chart many, many times, but this is from the Organization of Economic Cooperation and Development, life expectancy at birth and health spending per capita. And you can see I can make this chart look any way I want by skewing the Y scale, but basically we spend 2.5 times more than the average of other developed nations, and we live 2.5 years less. And the eye is a great predictor of that. A lot of diabetics have diabetic retinopathy. We can see that early on. We can see with OCTA the earliest signs of that. So hopefully these things, I'll just give you an example. I had a gentleman about 3 weeks ago call me up, desperate to get his wife some help. And when he explained the situation, and she was on the phone too, that it was way over my pay grade in terms of not being a chronic condition. This is something that needed immediate care. And she didn't want to go to the ER. Her husband and I both wanted her to go to the ER. It was 1 o'clock in the afternoon. I said, I tell you what, let's let the labs, the testing decide, not us. And we were able to order tests, and we got the test the next day, and LabCorp called me up and said there were some critical labs there. So she used the labs. The labs motivated her to go. Okay, I won't go into the rest of the story, but I'm hoping that eye pathologies, when you understand what they mean in terms of your overall health and longevity, will motivate you to get care. That's the most important thing that eye testing can do for you. Drops, I'm not a big fan of those. That's symptomatic treatment. Surgery, very seldom. Am I interested in that? If you have a retinal detachment, why did you have a retinal detachment? I mean, you have to have it reattached, but did you have a significant traumatic event? Or is there something pathologically or physiologically wrong in your retina that allowed that, the tissue down back there to be weakened and compromised? So question everything. And, if someone says, you have a retinal detachment, we're going to surgically replace it. And then when you ask the question, why did I have a retinal detachment and my twin brother didn't? It's like, don't believe their answer because they don't know. They don't understand the 4 mechanisms of disease, generally, with all deference to Dr. Loudon.
I just want to reinforce the issue that what we're dealing with is that most doctors, in general, treat symptoms versus underlying causes.
Yeah, and the reason why I use retinal detachment is because you wouldn't think of that as having an underlying physiological or pathological component. But I've had so many people, and the ones that are having retinal detachments have bad blood profiles. So their body is in a dearth of repair and recovery versus deterioration. So these are the kinds of things we need to look at. So, oral health impacts your system. Some of the objectives here: oral health impacts your systemic health in your eye. The eye provides a means to perform tissue biopsy in the living. We're literally doing a biopsy. I forgot that point, but that's a great term. The lens is a giant stem cell. So, you can get stem cells, but if your endogenous, your own stem cells are a mess, and your lens tells us a lot about that, then you're going to waste a lot of money buying exogenous or stem cells that are being injected or placed in you, unless we correct the underlying environment that caused your eye stem cells to be compromised. OCT is superior to MRI. They're very similar techniques in terms of measuring three-dimensional, creating three-dimensional images of tissue. But because of the type of light that they use, OCT is far more precise and accurate at measuring tissue changes. So an MRI may look at the brain and see very little going on, whereas the OCT of the eye shows something significant. It's all about precision of the testing. Over a dozen markers in the eye paint forensic pictures of systemic infection and inflammation. And I only use 3, the big ones. Eye pathology may help patients understand the spread of focal dental disease. This is a chart I use to train some biological dentists on the connection between eye pathologies and disease. So I left that in there as this. And then, this is the whole thing about, about the silos in medicine. We've got to look at we got to look at every part of the body in relationship to any pathology in any part of our body. But the eye is a particularly good one. More people get eye visits than get primary care visits from the last statistics I looked at. So optometrists have a unique opportunity to really help you understand their health if they're willing to take that step. And I'm working with a few optometrists, particularly good ones. Kerry Gelb, the head of All Docs OD, Dr. Scott Edmonds out of Philadelphia, excellent doctor that understands functional medicine. He's the eye consultant to United Healthcare, and he's working on helping eye doctors do more screening for whole body diseases in a project down in Louisiana, which was held up by COVID. But there's every reason in the world to screen your eyes to see what kind of risk factors you have, because the longer you live healthy. If you die at 80, you have 19 years of declining health. You die at 100, you only have 9 years of declining health. So your health span increases by 30 years if you take your eye testing seriously. So, Dr. Tremp wasn't the only one, but John Dowling here, chair professor at Harvard in ophthalmology, more of a researcher, and he just points out what we already know. You can get his book. It's a complicated read. It's more of a textbook, but the retina, the approachable part of the brain. He says the retina provides an excellent source of material for detailed anatomical and physiological analysis, and also pharmacological. Dr. Tremp's the only one I know, except maybe Shailesh Kaushal. Shailesh, I give you credit here today. A very brilliant MD PhD out of the Villages down in Florida. That pharmacological means measure, see the pathologies, treat, remeasure, and see if there's change in pathology. That's what Dr. Tremp did over a 47-year career. He started doing eye and systemic disease work in 1980, and he retired in around 2010. So that's a 50-year career of constantly doing this iterative process. And a lot of the more aggressive treatments that we use in our program all came from Dr. Tremp's work, looking at the eye, looking at the brain, looking at blood, looking at chronic infections, looking at all the things that we talk about. So a couple other images. These are 2.0 images. What about the blood-brain barrier I've heard about, and how does that relate to the eye? Well, sometimes they use air or silicone in surgeries to stabilize the lens when they're doing the cornea, when they're doing surgery. So you put an air bubble in the eye, and not too long thereafter, through MRI, it shows up in the brain. It's like there's a direct pathway. There's no blood-brain barrier here to the brain. Okay, and here's a drop of silicone. You put it in the eye, it turns up in the brain. So the connection between the eye and the brain, and what Dowling says is really the eye is an embryological outcropping of the brain, and the underlying processes in the eye are exactly what's going on in the brain. Now, there are many compartments in the brain, lobes, whatever, but so that, there's not complete titration once again from one to the other. But from a screening perspective, there's nothing closer to discerning what's going on in your brain than to look at the eye. And if you look at the brain, you should then look at the eye. Why? Because more precise measurement. Dr. Tremp and I are slowly working on publishing a paper from his data. And he's the only one in the world I know of that showed improvement in retinal ganglial cell volume and thickness back in the retina. So we call it the retinal nerve fiber layer. And I'm working with a couple people now where we're tracking with OCT the thickness of their retinal layer. And one individual over the last 6 months showed a 2% improvement. This is a person who's aging, okay, and usually you don't expect improvement in that thickness, and we'll continue to track that. So, what I have towards the end of this talk, which will definitely happen next week, is some data that shows that if you stop the inflammatory process neurogenesis, the genesis or growth of neurons, will or can occur. Okay, so all this tissue can be rebuilt regardless of age. Obviously, the older you get, the longer and the more challenging it'll become. But it's never impossible. So here's another doc. I walk from UC San Francisco. It says the same thing.
Tom.
Yes, sir.
Charlie here.
Yes, it is, Charlie.
I think that's one of the most important points that you've made in this conversation, in this discussion. Stop the inflammatory process, and neurogenesis can reoccur.
Yeah.
Do not forget that. That should become a mantra. Thank you,
Charlie. I remember that. I actually have it in. I'll probably present that because I have time to talk about. In the end of Alzheimer's book that Dr. Tremp and I wrote, in chapter 11, we highlighted a paper by Monge, M-O-N-J-E, published way back in 2003, and the title of the paper is "Inflammatory Blockade Promotes Neurogenesis." And in my book, I break down that paper, their medical science speak, and then I broke it down into lay speak, and explain exactly what they did and how they showed that you can rebuild neurons. Okay, but only if the inflammatory. And all I say simply, Charlie, in terms of understanding this, we do not send babies to war. Stem cells, progenitor cells, are what starts the rebuilding process. And when your body's under attack, inflammation, that's your immune system activated, those things shut down. It's that simple. And I appreciate you saying that. So I am going to play a short video by me. Health clinics is to provide solutions for Alzheimer's disease and other neurodegenerative diseases. Today I'd like to explain to you how we believe at Real Health Clinics that Alzheimer's is a vascular disease. So, big question, is Alzheimer's a vascular disease? Because right now, Alzheimer's is being managed as a disease of the brain only. And same with the eye. Cataracts observed or extracted. Macular disease is observed or mismanaged. We'll talk about that. Glaucoma is a disease of pressure according to the standard of care. So they're reducing pressure. And I just had a lady come to me after being at Mass Eye and Ear, and her ophthalmologist there said, we'll manage the pressure, but we don't know what causes it to go up. So all the eye diseases and Alzheimer's completely overlap in terms. So when I say Alzheimer's, take any eye pathology and substitute the word in. But I'm suggesting that we need to go beyond the brain to find solutions. So is Alzheimer's a vascular disease? So I just want to look at a very simple continuum, from heart attack to stroke to what are called microbleeds and microinfarcts to vascular dementia to Alzheimer's disease. All four of these are considered vascular disease, or at least have a significant vascular component, whereas Alzheimer's disease is not. So let's just go through this and take a look at where the misunderstanding may be. So in a heart attack, a major vessel feeding the heart is blocked off in some way, and so the heart suffers from a lack of oxygen, lack of blood flow, and you have a heart attack. The next part is stroke, where a major vessel in the brain is blocked off, leading to hypoxia, lack of oxygen, in a significant section of the brain. And the next would be microinfarcts, and all we're doing is going to smaller and smaller networks of vessels in the brain. And this is well known. We can see this in MRI, these so-called microinfarcts and mini strokes. So the next level is vascular dementia. Once again, we can see in the vasculature with MRI that these very small vessels are impacted in what we call vascular dementia, symptoms similar to Alzheimer's, but classified as vascular dementia. And what I'm positing is that Alzheimer's disease is way down here at the capillary level within the brain. And the reason why Alzheimer's disease develops so late in life is we have so many capillaries that we're losing just one capillary at a time and a second capillary, and then we get this additive effect on the diminution in brain function, because you need capillaries functioning well to support the neurons in the brain. So let's look at why there may be a misinterpretation as Alzheimer's being a vascular disease. So here we have heart attack, stroke, microbleeds. These are big vessels. And the carotid artery is as big as my thumb, if not bigger. So vascular dementia, why I have this red circle here is, from a scale perspective, this is how big a small microvessel is that's tied to vascular dementia versus a capillary. A very significant difference in size. And basically, the main technique that neurology uses to determine whether it's vascular dementia or Alzheimer's is MRI. And MRI cannot see, it doesn't have adequate resolution to see the capillaries. So when you take an MRI of the brain, you can't see if this tissue is healthy. So the presumption is it is, when I believe, and we have techniques to show, that it is not. So let's just take a look at what we see here. Quantitative assessment of the retinal microvasculature using OCT. So what does that have to do with anything? First of all, we use the eye to do early detection of Alzheimer's because the eye, particularly the retina in the back of the eye, is an embryological outcropping of the brain. And OCT is very similar to MRI, but it has much higher resolution optics. So since the eye is transparent, we can use this so-called tomography technique to look in the back of the eye and get spectacular imagery like this, where we're literally going down and seeing capillaries. So when we do OCT on dementia, Alzheimer's patients, we see abnormalities in this lowest level vasculature. So if we look at this, Mayo Clinic and the Alzheimer's Association are saying they're providing hope, a new frontier to study Alzheimer's, 2017 special report. Every one of these folks is a neurologist looking brain only, and when you read the report, no one's using the eye as a looking glass into Alzheimer's. So I'm not particularly bullish in terms of what the pundits are going to be doing in the future to diagnose Alzheimer's. That's why we formed Real Health Clinics, where we do this. So they call it the next, not the final, is a brain-only approach. Team lacks diversity. The final approach is to look at really the genesis of the disease, which I believe is in the capillaries. So conclusion, Alzheimer's is a vascular disease of the capillaries. Alzheimer's slowly progresses as capillaries die off. MRI cannot detect the underlying cause, and that's the major technique used in PET scans, which also can't see capillaries, to diagnose the root cause of the disease. So the root cause is being missed. OCT can. Very few doctors in the world are using OCT to measure neurodegenerative diseases like Alzheimer's. Real Health Clinics, we do that. So Alzheimer's is, or at least has a significant component that is vascular. Is there a recommended dry eye grade severity index test? Not that I know of in terms of, there's a lot of the American Optometric Association has a number of standards, but they're not really super at asserting standards. There's various standards. But see, I look at the underlying pathology of dry eye. Is it a lack of lymphatic drainage, a lack of iodine? Are you beginning to have some infectious process? Do you have Demodex? Any number of reasons that might lead to that. Recommendation for the best type OCT. Do all use Zeiss? Zeiss is a really good one, but I think optics is now, just like with our phones, the cameras are also good. So I don't think there's a big issue there. Charlie, do you have a question? Oops, you're on mute. Charlie, you're on mute, so.
No, I didn't have any questions.
Okay, fine. Someone asked, can cataracts be reversed? The answer is yes, but very slowly. I didn't get to that yet. We'll get to that probably next week. But the lens where the cataract is the largest single cell in your body, and it's extremely avascular across it. It's very unusual in that respect. So it takes a lot of time for any process to reverse, but we've seen it. And then there's some inference that L-acetylcarnitine helps reverse cataract. I keep meaning to look into the detailed mechanism of how it works, and I believe it's an anti-inflammatory, maybe even slightly anti-infective, so it may be a useful thing. Cataract surgery is the #1 surgery in the world. I'm not opposed to cataract surgery, so you can have great vision with an artificial lens. But like Richard Loudon said at the beginning, Dr. Loudon, if you're having cataract surgery at 50 or 60, you better get tested further for underlying pathology that can be contributing to it, because you just don't. A lot of people say, oh, you've been exposed to a lot of sunlight, you're a sailor, you've been out in the water. I don't buy into that at all. I believe that cataract is an amyloid process. It's a part of the innate immune response. And it's not a response to extreme light. I mean, we're supposed to. I never wear sunglasses. I wear my blue blockers here, but the sunlight is good for our eyes, not bad. As long as we have good repair and recovery pathways. That's my general opinion. I'm not saying it's 100%, but how do you know if an OCT provider are using the most updated software? You got to ask that question. If they have an OCTA, they're on top of it. If they have a regular OCT, they're still amazing instruments. I mean, Dr. Tremp was using OCT 20 years ago to accurately measure retinal thickness and retinal volume and changes. So, those instruments it's the nature of the light they use that interacts with the tissue that determines the resolution, and they're all using the same light. My ophthalmologist recently acquired the OCT machine, and I got my first OCT diagnosis last week. It's good to hear about its importance. Yeah, it's very important. Very important. Doctors wait until you are so diseased. So true, Maura, yeah. Will the eye give indications specifically of oral infections? I mean, the only way to get specific on the oral infection is to test for the oral infections. But the connection between macular disease, glaucoma, cataract, and oral pathogens is an association. But the association is extraordinarily strong and well published beyond mine and Dr. Tremp's work. But I can tell you there's almost not one person that's come to me with glaucoma that doesn't have something going on with the mouth. Not everyone, but most of them. But it doesn't tell me exactly which pathogen. That's somewhat irrelevant, but it's good to know, and it's good to do the oral DNA test so we can see what the levels are and make sure our treatments are working. Because we always want to know that we're heading in the right direction. 7 to 8 OCTs before level ganglial cell loss picked up. 4 different OCTs. I can't comment on that more. I have to see the data. But it's still, no technique is perfect, but at least it has resolution down into the microns. So, it's a question of what they're looking at. So, there are ranges, and all the OCT data is based on age. So if you're 50, you're being compared to OCT data from other 50-year-olds. Okay? So, but really, just like with labs, we interpret them differently. We should be looking at the micron thickness of each section of the layer called quadrants, and not worried so much about their color coding, about whether you're in the 95th percentile of your age population or not. So that's what the report gives. What I look at is what I expect for standard thicknesses of the tissue in the various layers. And I think that would be a much more, maybe that would have given you a clue. It's just like white blood cells. 11,000. When you have 11,000 standard of care normal, you're fighting something serious. It should be 4,000 to 5,800. Same with thickness. When do they start considering diminution in thickness significant. So I think that could be part of it. RNFL, retinal nerve fiber layer. Can you explain more? Cells involved, significance of test. Well, the retinal nerve fiber layer, this is 2.0. I suggest you read John Darling's book on the retina. But there are different layers that correspond with different parts of the brain. And the OCT as a commercial tool doesn't really necessarily define what's going on in terms of the thickness in each layer per se. But in the research realm, you can definitely titrate the different layers to different areas of the brain and therefore pathology. But what we're doing with OCT is we're still measuring very precisely the overall thickness, which will give us an idea of what's going on from a neurodegenerative process. It would be great to have a complete list of inflammation tests. Steve, we have a couple different of those on our website. The number one is our chronic disease temperature. Number two would be to run the infectious panel, because that's the chronic disease temperature with infection. And then under COVID, we have our chronic disease temperature with a few extra inflammatory markers included in there. So I think there are other groups doing that. I just listened to the IFM call this morning on COVID, and they're all doing, uric acid, D-dimer, things of that nature. But, what we do with the chronic disease temperature is we try to find the lowest cost, highest value list of inflammatory markers that we possibly could as part of our panel, and then decide if we need to go to level 2 testing. But normally I don't need more cytokines or inflammatory markers. I need to titrate more to causes. I don't need 10 inflammatory markers to be up to know you have inflammation, is my point. But believe me, the functional docs are very happy to run every one of those tests. Understand the retina, most mitochondrial dense area of the body. Mitochondria is just like a muscle. If you're working it all the time, those cells will have more mitochondria. So there's no question that the retinal ganglion cells are working very, very hard all the time. I've heard that cataracts can also be contributed to a high sugar diet. Yeah, absolutely. But see, the sugar diet usually infers more inflammation, but it also infers lack of micronutrients, because most sugar diets are low in nutrient density. And so if you're low in nutrient density, immune cells need those nutrients as well to flourish at high or optimal level. And in those cases, there's a lot more infectious disease. So Dr. Tremp told me 20 years ago, diabetics almost always have high titers for chlamydia pneumonia infection, which is an infection that's chronic, that's ubiquitous, that gets into the blood vessel. It causes endothelial or blood vessel dysfunction. So yeah, the sugar is way down from the actual causation, but it's an exacerbator of the proliferation of mechanism 4 chronic infection. Where is your son located to make an appointment with him for OCT, etc.? Well, thanks very much. He is in Keene, New Hampshire. But there are other good if you're in Keene, New Hampshire, definitely go see the A-man, Aaron Lewis. He's a very good, compassionate eye doctor, and he gets great reviews. And he trained under Dr. Tremp briefly to the extent that he was allowed to during his education at the New England College of Optometry. But go to All Docs OD or Vision Source. These docs are working at a pretty high level as well. Greetings from sunny Bermuda. Sounds like you've been here. I've been here a couple times. I was at the All Docs OD convention almost 2 years ago, presenting somewhere in the center of the island by the ledges, where we love to go kayaking. So invite me back to give a talk. I'll go to Bermuda any day, particularly late spring. Any changes noted post-COVID with this test? That's interesting. I'll be discussing that next time on eye manifestations from COVID, but I can't do that now because I'm late, almost. And what are the findings on the D-dimer with COVID vaccine? You know, if you listen to the talk from the IFM that I listened to this morning, and send me a note more and I'll post it, they mentioned a number of research papers that are looking post-vaccine at cytokines and other markers. And I frankly have not read that paper yet, but it's one of the things I intend to look into. So, and with that, we're right on schedule. So next week, a lot more on eye and systemic disease. And thanks very much for attending. Bye for now.
Thank you.
You're welcome.